Hey, hey, Eric, we were probably good to go if you want to kick
Yeah, I was
things off here.
just looking at the list here. I was just giving some people some more time to get on.
Yeah, with
Um,
your at your leisure.
but we can let you guys ask a couple questions if you have anything about last week, what we were discussing, or about the module that you guys just got through. Otherwise, we're gonna get into kind of the fundamentals today of the thoracic region. Start in on that stuff. Any questions? Anything you guys want to clear up? No? All right. All right, so let me share. You got share enabled here, Dave?
Should be.
All right, all right, looks pretty good. You getting that?
Mhm.
Okay, gotta move you guys around here so that I can actually see what I'm talking about. All right, so this is basically the fundamentals presentation that I typically go through on the first day of module three. Okay, so basically this is one of those things we would spend Friday afternoon on in most cases. And what the hope is, and we've talked about this previously, is that we'll be able to get through some of this didactic stuff over these Zoom calls, get you guys really pretty comfortable with this stuff before we get into the on-site intensive. And that'll give us a lot more time to go over the different techniques, to get a little bit deeper into those things, to give you more practice, more times for questions, more time for cases, and hopefully give us some time to go over some, what I consider kind of the rehab components or exercise-based, movement re-education, all that sort of stuff, as we get toward the end of the weekend for this next coming intensive. So feel free to jump in if you have any questions here. Hopefully, what we'll get through today is we'll get through most of the anatomy stuff. I've kind of started outlining this in a Google document for you guys, just so you can. And this presentation is on the website as well. It looks like I've made some adaptations to it. It's not anything real significant. I think there's one additional slide that I've put in as far as biomechanics go. It will be on the Google Doc. Um, and I'm adding in some more in-depth things for the visceral pain, visceral components of this sort of examination as well, just to get a little more in depth about the neurology of how that functions, and how it's going to differ for us compared to somatic pain or potentially even lancinating neurological pain that we might get throughout the thoracic region. Okay, so there will be some things that are a little bit different in this document that we're looking at right now than the one that's currently on the website. But again, the Google Doc, we're going to kind of update as we go through. And again, I usually mention this at the beginning of pretty much every course, but the fundamental stuff that we're going to look at: anatomy, biomechanics, and a lot of physiology stuff. And if there's anything that you guys think that you're lacking on, if there's any particular body region or any topic that we go over where you're wondering, am I up to speed enough going into one of the courses? This is the stuff that I would recommend you focusing on: the anatomy, the biomechanics, and then the physiology stuff. Okay, so we're going to go through quite a bit of that stuff over the next 3, maybe 4 weeks. It depends on how quickly we can kind of get through these things. I will do a section on respiration, which will probably also have some components of blood chemistry and how respiration and altered breathing mechanics can affect the physiological responses of the body, and how that might present in a more physical manner, something similar to what we've seen in the past with talking about things like segmental facilitation. So altered respiratory mechanics, and how the ventilation mechanism of the movement of the ribs and whatnot, how that can affect blood pH and some of those sort of things, and how that can kind of create some physical manifestation. So we'll have another whole um, segment about that. We may talk about that over the course of a couple of weeks, depending on how in depth I want to get on that stuff. But it is important stuff. So we'll start out today with the anatomy. And again, I tend to go into mostly very deep dives on these sort of things, because I think the more you understand about the functional anatomy, how things actually function, basically how the morphology, the shaping, the orientation of these different structures, how those affect things like the biomechanics, how those affect things like functional movements and the interrelationships between the thorax and other functional regions of the body, such as the shoulder girdle, pelvic girdle, the lumbar spine, the neck, all of these different things. So I think the more we know about the functionality of these structures, the easier it will be to relate these things to the various physical pathologies that we run into. Okay, and again, that'll be more of the stuff that we cover during the intensive. Um, and it should hopefully at that point make a lot more sense to you, and hopefully we'll be able to get a lot more out of the weekend courses with that. Okay, so first things first, here's kind of the five major functions of the thorax, okay, at least from my perspective. Okay, so number one, the cage in general is designed for protection, right? It's supposed to help protect the viscera, the heart, the lungs, etc., um, as well as a lot of vascular tissues, things like the aorta, aortic arches, the subclavian arteries, all these different things, the lymphatic tissues, as well as a lot of neurological structures, including the spinal cord itself. Something important to note is that the spinal cord itself, where we have upper motor neuron potential, ends somewhere around T12L1. Okay, so this is something that we don't tend to think about too much when we look at neurological symptoms, is if we have upper motor neuron symptoms in the lower extremity, it means that we have at least some sort of problem within the thorax, if not higher, right? We cannot have upper motor neuron symptoms that are developed from a lumbar um, canal issue. These will still be lower motor neuron issues, and that includes things like cauda equina. Okay, so we have to take that into consideration. Those are lower motor neuron issues. Basically, from L1 down, there are some anatomical variations. It may differ from one person to the next, where the cord itself actually ends. But in most cases, it's going to be right at that TL junction region between 12 and L1. So we have to take that in consideration if we have lower extremity upper motor neuron symptoms. The neurology of that suggests that the problem is someplace at least above L1. Okay, so if that makes some sense, we have to take that into consideration when we find that sort of stuff. So respiration, again, we're going to get more in depth on this as we go through in some of these later Zoom calls here. But basically, respiration in humans should be very efficient and providing good mechanical movement, and it does affect blood chemistry, the blood pH. Okay, so if we start to have excessive blow off of carbon dioxide, which tends to be what happens when we hyperventilate, things of that sort of nature, it will actually make the blood more alkaline. And so that can cause all kinds of different issues with the body as far as from a mechanical standpoint, how it affects position of the head, position of the mouth, whether we're actually able to breathe through the nose or if we become more mouth breathers and things of this sort of nature. It can kind of perpetuate some postural dysfunctions relative to how these blood chemistry issues are registered through the central nervous system. Most of that sort of stuff will occur in the carotid sinus, so here in the neck, and that will kind of tell the body how we need to position the head and the jaw relative to the head and the cervical structures as well, so that we either need to blow off more CO2 or need to retain more of it. Okay, so that's again something we'll go over a little bit more in a future session here. One thing that we do need to take into consideration as far as the mechanics of respiration, just with the anatomy, is that we do have humans in general, we have what we call a negative pressure gradient with breathing. So as the diaphragm contracts and the chest wall starts to expand, we have less ambient pressure within the chest wall. And so the air is actually passively drawn into the system there. And it's different from a comparative anatomy standpoint. With things like birds. Birds have what we call passive airflow, where they actually blow air in actively. It's more of an active process. So again, if we are unable to create this increase in chest wall expansion, whether that's at a particular region of the chest wall here in the CT junction region, down lower in the TL junction region, or the along the where the diaphragm is. This will affect that negative pressure gradient. It will diminish the amount of air that we're able to bring in from that negative pressure. That will affect our tidal volume, and obviously that's going to affect oxygenation and a bunch of other systems that go along with that, right? So that's something that we do have to take into consideration. The next two things here, the transference of loads and postural stability and mobility, I would almost tend to group those two things together. Um, Basically, the idea is the thorax is what we call a great adapter. Gail Malloy used to call it that all the time. Very flexible, very pliable region of the body. There's something like 136 joints within the thorax. I think it depends on how you view some of the manubrial joints and things of that sort of nature, whether or not they actually move. Um, but it provides a very flexible yet stable platform for things like pushing and pulling, lifting and carrying, all of these different things, and it helps us to attenuate the various loads that the body is forced to undergo just because we live on the planet Earth, right? We all deal with gravity. We all then deal with the corresponding um, ground reaction forces that come along with that. Okay, so those are things that Diane Lee has talked about. You'll hear us mention her name a lot in the thoracic segment. She's done a lot of work on the interconnectivity between the thorax and other body regions. So again, we'll talk quite a bit about that as we go. Um, but because of gravity and because of the ground reaction forces, as we move, the body will tend to twist and contort. And so the scoliotic curvatures of the spine, the natural scoliotic curvatures of the spine, which we call an S curve, allows us to accommodate for those forces and allow us to keep moving forward in an efficient and effective manner. Now, when we look at these scoliotic curves, the other things that they do is they help us to produce passive energy. Okay, so when we walk, what we see is, say, my right arm is swinging forward. That would mean that my left foot is moving forward, right? So I have an opposite torque here of my trunk with my lower extremity, right? So what that does is it twists the spine, right? And so when we do that, as it twists, it actually compresses as well. And that's what creates this kind of S-shaped curvature of the thorax down into the lumbar spine and then through the pelvis with the sacroiliac joints. And the thing that I think is most efficient about this is we tend to think of things like the bony structures of the body as very rigid, but they're not. They're actually very plastic, very pliable. And we have a lot of capability for these tissues to distort. Think of it more like trying to twist a plastic ruler, right? So it's not rigid. It actually has some pliability to it. It's much more similar to that. The osseous structures are much more similar to that than they are some sort of rigid mechanism that doesn't have any give to it. When we start to consider that possibility, we can start to consider the idea that as we create these torsional effects through these osseous structures, once that pressure is released, right? So say once we lift our heel from during striding, then all of a sudden that energy is released and the structure will spring back to its normal morphology, right? And so that's a nice mechanism that the human body has developed to help produce passive energy for things like gait and so ambulation, right? It's what tends to make human bipedal ambulation the most effective form of locomotion in the entire animal kingdom, right? So between that and the pliability of, or sorry, the elasticity of ligaments, joint capsules, tendons, muscular tissues, all of these sort of things that can stretch and then recoil, we really have a very efficient mechanism for producing the transference of loads while maintaining postural stability and mobility. Okay, so it's really important that we start to kind of consider that stuff because it does play a role in what comes into the clinic. If we have somebody that comes into the clinic with, let's say, um, midfoot pain, right? The midfoot's a very mobile structure. There's a lot of ligamentous structure, a lot of joints, so a lot of connective tissue, joint capsules, all that sort of stuff. Um, it's a very mobile area that's able to produce a lot of elasticity and helps to provide some of this passive energy generation during ambulation. However, if we take into consideration the idea that we're unable to move effectively through somewhere like the TL junction, which should be probably the second most mobile portion of the spinal column after the craniovertebral region, if we can't move through that TL junction, all of a sudden we have to add that energy back into the system with ambulation. So now we can have over-adaptive or adaptive hypermobilities that start to occur in some of these other body regions, like potentially in the midfoot. Or we have to start adding in more muscular effort in order to maintain the same amount of natural energy that's able to be expended during gait. That could create tendinopathies or insertional tendinopathies of, say the hip flexors, the hamstrings, the Achilles and gastroc mechanism. So any of these areas we can start to have overuse or what we call forced overuse syndromes that'll start to create, reasons for patients to come into the clinic. So if somebody comes in with, say Achilles irritation, we look at it and say, okay, well, we're going to look around the ankle, we're going to look around the foot, we might look around the knee, these different areas. We might ask them what they've been doing differently, da 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 da, not really realizing that, hey, they're not moving very well through that TL junction, and all they're doing is trying to add that energy back into the system. There might not be anything structurally or mechanically wrong with the foot and ankle mechanism or the knee or the musculature itself. It's just that it's where they're adding that energy back into the system because of a loss of mobility through the TL junction. So again, really advanced stuff. We'll talk a lot more about those sort of things as we get into modules like 7 and 8, as we're starting to bring all these different body regions together. But it is important for you to kind of understand that those things are possible, okay, as we go through that. Coordination of movement with the upper and lower extremity. Earl Pettman talks about this a lot, the integration, load transference, all this sort of stuff. Basically, we have to be able to provide a stable base for the different girdle mechanisms to function properly, right? And we talked a little bit about this during the conversations that we've had about force output testing, the idea of regional inhibition, meaning if I don't have a stable base here through, say, my CT junction, I'm going to have natural inhibition of some of the shoulder girdle musculature, which might include the parascapular musculature, it might include the rotator cuff, it might include the bicep or tricep mechanisms, might include things like the lats or things like the splenius capitis, splenius cervicis, these different muscles, all these things that attach to and are affected by the thoracic mechanics and stability. Okay, so we have to be able to make that kind of coordination as far as things go with the various movements of the associated structures, head and neck rotation, all these different things, the thorax and its ability to coordinate these movements and assist with these movements plays a huge role in that. All right, so as far as anatomy goes, I always break this up into 3 functional regions. The CT junction, I used to have this down as just the first 3 rings, but realistically, we have to take into consideration the interaction with C7 as well. We'll get into, and we'll probably do an entire Zoom call on the mechanics and the orientation of the CT junction in a few weeks here. But knowing that those first 3 rings, they function very similar as far as their biomechanics to the lower cervical spine, right? So we're going to have kind of ipsilateral coupling with movements like head and neck rotation, side bending, flexion extension. They should operate very similarly as far as those first 3 rings go. And that does include, the reason I put first 3 rings is it does specifically include the ribs there as well. The mid-thorax is really a lot more of what we're going to talk about probably today, because we're looking more at kind of the quote-unquote typical anatomy of the thoracic segments. So T4 through T9 is really where we're going to be kind of focusing on that. The TL junction, T10 goes down all the way through L1 as far as functionally how these segments will operate. That specifically is important to note because it will affect our evaluation process of the TL junction. Um, a lot of, I think, kind of schools of thought will not look at 10 on 11 or even necessarily um, T11 on T12, but the anatomical variations that we have there and kind of the functional combined movements that occur through the TL junction to allow the attenuation and absorption of rotational forces coming up from the leg through the pelvis and lumbar spine into the thorax. That the mechanics of that really extend all the way into the T10 segment. So we have to kind of take that into consideration as we look at it from a functional perspective. Make sure I got everything here. Yep, gating mechanism. Good, good, good. Okay. All right. So here we are, finally, 25 minutes in here, looking at what the actual orientation of this stuff looks like. Now, I know this is from Netter, and this is, there's some artistic variability that goes along with this, but relatively speaking, this gives us a pretty good look. So mid-thoracic vertebra, I think T6 is kind of the idea here, but there are some things that we have to kind of take into consideration when we compare this both to the cervical spine and the lumbar spine. Okay, so some of those things are the transverse processes here, right? So they have more of what we consider a posterior or posterior lateral orientation instead of coming out more straight laterally, like they do in both the lumbar spine and the cervical spine. And what this does, this actually changes as we go from superior from the upper thoracic region to the lower thoracic region, right? So this is much more posterior up high, and it kind of continues that way as we go down. But what it does is it's going to allow for more expansion of the chest wall because the ribs themselves attaching here to the vertebral body by the costal facets and then the transverse costal facets, this acts like a very typical bicondylar mechanism where the ribs will kind of glide in this posterolateral and then anteromedial method with inspiration and then expiration. So inspiration creates this kind of posterolateral movement, and exhalation there will create more of an anterior medial movement of that. But that is purely based off of why that occurs is based off of the orientation of those transverse processes. Other thing is we get more of this triangular shaped central canal. It's significantly smaller than what we have in the cervical spine or the lumbar spine. And basically that's because we don't have any limbs to be controlled by the nerve roots of the thoracic spine, right? We don't, the upper extremity musculature, upper extremity sensory, all those sort of things, those come out of the cervical region. So we have more nerve tissue that needs to be housed there. Same thing in the lumbar spine. We have the legs, lower extremity components that have to be supplied from there. So the amount of space that needs to be present for that central canal becomes significantly less. Now, that does create some potential issues. If there's anything that starts taking up space in here, whether that's a disc protrusion, some sort of vascular malformation, an aneurysm, tumors, osteophytes, all these different things that we kind of think of are, problem that could potentially be problems with that central canal. There's less space for those things to go in there. Now, we tend to look at this sort of stuff and we say, okay, the body only gives us enough space for the neurological mechanism as it needs to perform its function, right? So that's why this ends up becoming significantly smaller here. It also affects the amount of vascularity that we can have going through this area. Okay, so the radicular arteries are the arteries that will come off of the external blood vessels and go in through the intervertebral foramen to help vascularize the thoracic cord. In most people, they will not have one of these radicular arteries at every single level of the spine. Okay, so in fact, in a fair amount of people, I think it's up to 32%. I'd have to look it up, but it's in that general vicinity. they only have one major radicular artery, and it's called the artery of Adamkiewicz. That's just the name of it. You can look it up if you'd like. Um, we'll talk more about that as we get into the vascularization of this stuff as we go down here. But that becomes very significantly problematic if we have something that affects the flow of a singular radicular artery, or if there are just a couple of them. How do we maintain enough vascularity to get into the cord within this region? It's what we call the watershed region. And again, we'll talk more about that as we go. What else do we got here? Orientation. Oops, sorry about that. I'll scroll down and make sure I got everything. All right. All right, rule of threes. This is not what I would call a rule. It's described as such in certain, literature and whatnot. But what that's talking about is the slope here of the spinous process. Really not very easy to see in this image here on the left. But as we come over here to the one on the right and we start to see, oh, look at how this thing slopes downward. What the rule of threes suggests is that every 3 thoracic vertebra, this slope will start to change significantly. Now, realistically, this is a much more tapered effect that occurs over the span of these segments. But in general, what it suggests is that the first 3 segments, T1, 2, and 3, the spinous process will be relatively even with the vertebral body, right? And even with the facet joints that are associated with that region. Okay. As we get from T4 down to T6, what we'll see is this becomes notably more elongated, and it will actually traverse about halfway through the next segment below it. Okay, so what that means is that these articular facets are no longer in line with the spinous process. Okay, and then from there going down even further, where was I at? 4 through 6, so 6 through 9, the spinous process is actually going to traverse an entire segment. So the tip of the spinous process is actually going to be an entire segment below where the actual joints are for that level. Okay, so if I'm palpating the spinous process, say of let's say T8, I'm actually even with the articular pillars or the facet joints of T9 at that point. That becomes quite important when we're landmarking and trying to find where our hand placements need to be for mobilizations, manipulations, PIVMs, PAVMs, all the different things that we do. Okay, so we do have to take that into consideration. Now, as we get below T9, we get to 10, 11, 12, it starts to reverse itself. So 10 is about a full segment below, 11 is going to be about a half segment below, T12, because it's going to be more similar to a lumbar vertebra than it is to most of the thoracic vertebra, it's going to be pretty much on line with where the facet articulations are going to be. So really the only reason I even mention the rule of threes, because there is a lot of variation. There's been several articles that have kind of quote unquote debunked the idea of that, but there is enough anatomical variation in most people to suggest that, especially in that mid to lower thorax, so somewhere between 6 and 9 or 6 and 10, we're going to have to pay more attention to where our hand placements are, because the spinous process, the tip of the spinous process, isn't going to be an adequate kind of locator or landmark for us to find those articular surfaces, those articular pillars. We're going to have to kind of be able to, use a gradient there to decide where does my hand actually have to be to produce a particular technique. Okay. I want to mention here with this stuff, the costal facets. Okay, so the vertebral body costal facets here. These are demifacets, meaning there's a half of this on the inferior half of the upper vertebra, and then also a portion of it at the superior half of the inferior vertebra. Okay, now what this means is that the ribs themselves are going to articulate with 2 separate vertebrae. Okay, and it does affect how we name these ribs, right? Because the first rib only articulates with T1. Okay, well, it doesn't have a demifacet mechanism. However, the second rib will articulate with both T2 and T1. Okay, so what that means is if this is the T6 vertebra, then the rib that attaches here to the superior costal facet and also to T5 is going to be the sixth rib, right? It means that if we go from the second rib down, the second rib attaches to 2 and 1. It means that the number is going to be based off of the inferior vertebra, the number of the rib. Okay, so that is something that we have to kind of take into consideration as well. It's more documentation related than anything else. But these demifacets are important when we start to look at combined movement components here, which again, we'll talk about during the biomechanics lecture in the next couple of weeks here. It tends to make these things function a little bit more like a U joint than it does like a pure planar joint. Okay, just because now all of a sudden we've got this rib that's taking up some of this space here. And as things move, it's going to create that same sort of translational movement that we would get through the cervical spine because of the uncovertebral joints. And again, we'll talk more about that as we get into the biomechanical processes. All right. So here's some relationships that I wanted to go over as far as where things attach. It's better to see some of this stuff from the anterior view. If we're looking at the interactions here specifically at the top between the manubrium and the sternal body and the xiphoid and where the different ribs will come into play here. Um, the first rib, very short, very blunt, but very wide and thick kind of in the mid body of this here through this area, sits directly underneath the collarbone here. Basically, if we look at this from this perspective, the edge of the rib here is going to be basically in the mid-clavicular line, right? So going to the mid-clavicle, that's about where the edge, the lateral edge of the first rib is going to be. That's definitely going to help us as we get hand placements for supine techniques where we're at the head of the bed and we're kind of working down on the first or the second rib, right? So that starts to widen as we go laterally here and go more inferiorly. And that also occurs with the costochondral joints. So the costochondral joints are much more narrow here at the top, below the clavicle. And then what tends to happen, and this picture doesn't do a very good job of showing this, but what tends to happen is it tends to arc outward as we go lower in the thorax. And so what'll happen is it'll kind of start here, probably a third of the way laterally from the manubrium toward the lateral portion of the shoulder girdle. About a third of the way across, we'll get into that's about where the costochondral joint for the first rib is. And as it goes down, it's really going to kind of come wider and almost go through the areola, that sort of region. And then it's going to almost come down to the point where the costochondral joints here for the lower ribs, basically 8, 9, 10, is going to be almost on your flank, right? So it's almost going to be all the way laterally to the side. And that is important because we can have damage to these costochondral joints that can be quite painful. And so we need to be able to palpate those structures in order to determine, is this the structure that's producing patients' discomfort? The articulation itself between the bone and cartilage is what we get is the end of the bone, the end of the rib here anteriorly is actually kind of cone shaped. It's a hollowed out cone. And then what we get is we get more of this pointed cone for the cartilage, and they sit into the cartilage sits into the end of the rib, kind of like that. Now we can certainly fracture this portion of the costochondral joint where we actually break off that conical shape of the cartilage within that end cap of the anterior rib. Not a lot we need to do with this sort of thing. If we basically just leave it alone, it'll heal itself up, which is good news. We don't want to tape it. We don't want to put any compression on this sort of thing because then what we're going to do is we're going to produce potentially these sort of things where the cartilage is moving against the end of the rib and it's not going to heal. Plus, then all of a sudden we have this potentially jagged structure poking into the visceral regions, into the thoracic cage, which is not good when we have things like the pleura and the alveoli of the lungs in those general vicinities as well. So just leave it be. Let them know it's not going to kill them, and it should heal itself up in over the course of 6 to 7 weeks, something like that. What else are we going to talk about here? So the
Eric,
first,
how about the more subtle ones you see? I mean, how often do you see somebody with a thoracic subluxation or a rotation dysfunction getting pain at that joint?
oh,
And
certainly.
that being the indicator.
Yeah, and that's a good point. I probably should have brought that up, but if we have a situation, so what do we have here? The fifth rib, something like that, where the T5 facet joint on the right side here doesn't move very well, right? And so what happens when we breathe, when we take breath in, we do slightly extend the facet joints throughout the thorax, right? If we take a breath in, everything kind of straightens up. We go into more away from thoracic kyphosis. We're moving toward thoracic extension, not necessarily into the point where we're out of the kyphosis completely, but that's the general movement that should occur. But if we have a facet joint that doesn't extend well, what we now all of a sudden have to do is we have to increase the movement of the costotransverse mechanism in order to make up for that loss of movement. So we get this kind of twisting of the rib against the costotransverse mechanism. That can irritate the costotransverse joint itself, or it can also twist the cartilage against the end of the rib here anteriorly, right? And so that can absolutely create, like a costochondritis or something similar to that, based on just a mechanical problem that occurs. So absolutely, that's definitely something that can happen. It can be more, what you'd call traumatic as well. Um, I've seen hockey players that have had this sort of thing where they're kind of up reaching to catch a puck, something like that, and they get a blunt blow to the side of the trunk there where they're all of a sudden not their ribs are more exposed. And so you can have quote unquote kind of sprains of those sort of things as well. So definitely there's a whole spectrum of things that kind of can occur at those costochondral joints. The same is true of the interchondral joints, which are here from T7 down through T10, where the um, rib cartilage doesn't no longer attaches to the sternum itself. It's going to attach to the costal cartilage of the segment above that, right? And so these interchondral joints can have those very similar problems as well. Going back to the first rib and the first rib cartilage here, this is more of a synchondrosis. What that means is it's a joint held together by hyaline cartilage, so it can get quite irritable when things don't move properly here, which is unfortunately something that happens quite a bit when we deal with forward head postures and issues within the CT junction. Okay, junctional points in general, CT junction, TL junction, craniovertebral regions, lumbosacral junctions, those sort of things, they're going to tend to have more issues than kind of the mid ranges of these areas as well. Just because we have anatomical changes that are occurring there. We've talked about the morphological differences between, T12 and kind of the mid-thoracic regions. So those things will tend to gum up a little bit more often. Now, I will say I do see a ton of mid-thoracic issues. I'm sure Dave will agree with me on that entire region 4 through 6 it's an issue all the time. I do tend to think that a lot of that comes from postural changes and how the body is trying to adapt and still be able to move the rib cage. And again, we'll talk more about that when we get to respiratory biomechanics. Second rib here is important to note that it's actually connecting to two different components here. It's connecting to the manubrium and the sternum. And so there's actually 5 separate joints here that are created in association with the joint here between the manubrium and the sternum, right? And that is important because as we breathe in, what we get here is we get a kind of a bowing kind of outwardly of that joint. So where the cursor is right here at that sternal angle, it will actually push forward or anteriorly away from the chest in order to help facilitate the expansion of the rib cage. Again, if we can't do that very well, because what that requires is extension of T1, T2. If we can't extend those very well, we can't expand the chest wall up here at all, right? And if we can't expand the chest wall up here at all, guess where we're going to have to do it? We're going to have to do it way down here, and we're going to have to force more movement out of the mid to lower thoracic structures in order to accommodate that, maintain the same tidal volume, and provide the appropriate oxygenation to the rest of the tissues of the body. Okay. Let's see what else here. Got that. Talked about that. Interchondral joints we talked about. Good. So the false ribs, or the floating ribs here, 11 and 12, you can see them here on the bottom. They don't have a costotransverse joint. All they have is a costovertebral joint. So what that means is it's a much deeper articulation, almost more of like a ball and socket type of articulation. And that allows more planes of movement in theory. Now, it doesn't typically produce a lot of other ranges. What it will typically do is kind of this calipering motion to help increase the lever arm for the quadratus lumborum and also help to provide an adequate anchor for the diaphragm before contraction. Okay, so because of what happens is those lower ribs, the quadratus lumborum kind of grows over those ribs. So it really stabilizes them pretty well. But with violent type of movements, I've seen this occur with somebody, turning their head and sneezing, or putting their trunk into an awkward position and sneezing. I've seen it with lacrosse players getting, cross-checked in the lower back, where these things will just kind of go in some sort of funny direction because they have the potential to do that because they don't have that second costotransverse interaction, only the costovertebral one. Can really produce a lot of discomfort. It tends to be right there on the lower flank, posterior flank, kind of right over where that QL region is. So in general, I'll tell you guys this right now. If you have somebody that comes into the office complaining of flank pain in that sort of region, so just below the lower ribs, just above the pelvis, get your finger into the QL, and most cases they're going to say, yep, that's where it hurts. That's the one. As soon as you find that, you're going to be pretty confident that you're going to have some sort of issue at either the 11th or 12th rib, T11 or T12. In most cases, that's going to be the problem region. That's where you're going to need to examine. So really nice because it can kind of give us a very direct line. Okay, this is where I need to take a look. Okay. All right. Got through all of that. Good enough. All right. Ligaments here. There's not a whole lot that we have to really take into consideration here. There are a few things that I want to show you guys. This ligament here, this kind of trident looking ligament here that attaches to both the superior vertebral body and inferior vertebral body and the intervertebral disc. This is called the radiate ligament or radiate ligament. Basically what this thing does is it becomes taut during full inspiration, right? So when we take a normal breath in, this ligament becomes very taut, and it has a very high density of type 3 mechanoreceptors in there. And what type 3 mechanoreceptors do is they actually inhibit muscular contraction. Okay, so there's a lot of different regions of the body that have this. The thoracolumbar fascia has a great deal of this sort of stuff. It helps to inhibit multifidi contraction, things of that sort of nature. But the radiate ligament here, the suspicion is because of that density of type 3 mechanoreceptors, once those ligaments become taut, it's actually what stops our normal tidal volume inspiration. Okay, and that kind of is what tells our body is we've taken a full breath. Now we can let the musculature relax, diaphragm relax, and we suddenly exhale. So that's a thought right there that if we start to overstress these things, then it's going to inhibit some of the diaphragmatic contraction that we might have. Why might these things become overstressed? Well, if we're not moving well through the posterior elements, things like the facet joints, and suddenly we're forced to move more through this bicondylar costotransverse and costovertebral mechanism, we're going to overstress these ligaments. Okay, and so that can affect the depth of respiration that we have, and again, start to affect things like blood chemistry and whatnot. So again, like I said, there's a lot of different things that kind of come into play there. Now, out here, this is the anterior let me get the word straight. Costovertebral ligament. This is going to be the structure that most significantly impacts stability of the rib. Okay. If you look at it from this perspective, this is the anterior portion here at the front of the vertebral body. These are the posterior portions here. There's not going to be a lot of potential instability going posterior of the rib on the vertebra, right? Because the transverse process is in the way, right? We have this nice bony mechanism right here to prevent a lot of posterior element movement. However, anterior movement, then not a lot of stuff holding that together from a bony perspective, right? There is potential for movement into this direction, into that anterior direction. This anterior ligament right here is really the one that's going to provide the most stability to the joint. So if we find, and I'll show you guys how to do this during class, if we find an unstable rib where it feels like the head of this rib is able to slip anteriorly with a posterior to anterior pressure, this ligament is likely the thing that's become attenuated and is no longer sufficient, right? So there's not a lot of stuff that we can do for that, but things like prolotherapy and whatnot to help stiffen this ligament, this is where that wants to be targeted, is that anterior costovertebral ligament, okay? The other one is this guy here. You see it better here, which is the costotransverse ligament. This thing is loaded with nociceptors, okay? So when we start to destabilize a rib or costovertebral, costotransverse mechanism, this is the thing that tends to produce most of the pain. Okay, so this is good to know because this is palpable if we can get deep enough. And so what we can do with that is we can actually do cross-friction massage to that tissue, help with desensitization, help with tissue healing, all those different things that come along with cross-friction massage. So again, the superior costotransverse ligament is going to be the one that tends to produce most of the pain response. It's not the only thing. Obviously, the joint capsule will be associated with that. Various other structures that are associated with this as well, just because of how they're put together. But again, this guy here, and then this is the lateral ligament. So this again is very palpable to us, and we can cross friction that as well. It's not as much resulting from, it's not going to give us as much stability, probably not as much reaction to pain. This more blends with the joint capsule of the costotransverse joint, but it's something that we have to be aware of because we may have to do some work with that as well. All right, musculature here. Again, not the best picture that we'd potentially find, but what I just wanted to demonstrate here is some of the interactions with other trunk regions for various muscles. Okay, so we can kind of take a look here. Splenius cervicis and splenius capitis. So that's these muscles here. They're coming out of the neck. They're going to come down. In some cases from the occiput, some of these slips are going to attach to some of the upper cervical segments, and they're going to come down kind of at this diagonal to attach to the lower cervical spine and the upper thoracic spine. Again, capitis is going to be up higher. It's not going to come down as far. Cervicis is going to come down lower, more toward around, I think T4 is where it kind of terminates. That's going to, again, be variable from one person to the next. But what these things do is they're meant to create a sling mechanism with the SCM, right? That should help to support some of the shoulder girdle, right? But issues in the CT junction where we have something like a forward head, or we have something where we're creating hypertonicity because of a segmental facilitation in the cervical spine could affect this stuff, could create some reflex inhibition and affect kind of the position of the head relative to the trunk. Oh, the iliocostalis. That's one of our favorites, right, Dave? So iliocostalis, basically it tells you exactly where it attaches, right? Ilium and the costal angles here of the ribs, right? And so, here we go. don't know if you guys are seeing that thing or not, but I always get this pop-up every week at the exact same time. So I always look at it from a perspective of we go SLI. So semispinalis, longissimus, iliocostalis is the most lateral. So what this does is it attaches to the inferior posterior elements of the tubercles of the ribs, and it comes down throughout the thorax, multiple slips here, attaching to multiple levels of the rib cage, and should attach to the PSIS. Okay, now hypertonicity of the iliocostalis caused by intersegmental thoracic dysfunction, facet joint lesions, costotransverse joint lesions, ring shifts where the entire ring has kind of gone either lateral or maybe even anterior, is going to potentially create elevations of the rib tubercle. When that happens, this muscle tightens up. It actually starts to get more of a stretch reflex, so it's going to kind of contract on us. And that can take this PSIS and draw it superiorly, creating a very notable anterior rotation of the innominate relative to the sacrum. Okay, causes a lot of SI joint problems. Okay, if we think about it from that perspective, again, we'll talk more about this probably in Module 5 about the sacroiliac region. If we take the innominate and we rotate it forward, relatively speaking, that means that the sacral base here is counternutating. So it's coming relatively posterior compared to the innominate bone. That's going to be what we call an unlocked position of the SI joint. The SI joint is much more stable when the sacrum is nutated into the pelvic ring. Okay, so the sacral base has gone forward. So if we're relatively drawing one of those sacral bases posteriorly, we're going to destabilize the SI joint in weight-bearing positions. Now, all of a sudden, we can get vertical shear between the innominate and the sacrum, and that can cause a lot of issues in the SI joint region. So again, very important to note the relationship there between these longitudinal paraspinal muscles and how it can affect the pelvis. That's another Diane Lee theory that's very, very useful in clinic. Okay, muscle testing. Yeah, we'll talk about that more as we go along. Basically, if we have facilitation of any of the parascapular muscles, so levator scap here, rhomboids, the lats, pec minor, any of these sort of things coming out of facilitations in the cervical spine, it can affect position of the scapula, and that obviously can affect the length tension relationships of the various other muscles that attach to the scapula there. Do you have something you want to add there, Dave?
Now, this is just a kind of a big concept that can be hard first off, but you see how we can play the SI joint off the ribs and the ribs off the SI joint, or the SI joint, because yeah, this iliocostalis can create a thoracic ring rotation. It can pull in the rib and create a dysfunction. It certainly pulls on the innominate. So it's kind of a nice thing to really kind of just get into your mind that how these two areas kind of can interplay. I get the question, the discussion board was how differentiating QL from iliocostalis. That's certainly going to be, palpation, point of irritation, what's the mechanism. But for us, I can look at the biomechanics and see, okay, if I have an iliocostalis, which is a little bit hypertonic or QL, what's driving it? What's not moving well? What can be potentially contributing to it? Is it a rib dysfunction or a ring dysfunction driving it? What's the motion state of the SI joint, the pelvis? Does it move well? Is it stable when they're loaded? And look at the biomechanics, because really when we look at the muscle tone, like Eric and I talk about, I'm really thinking about why is this muscle trying to do too much? Because many times they haven't had a history of an acute strain.
Yeah.
And it's being driven by something.
And that kind of harkens back to what we've talked about, that muscles don't just decide to get tight on us, right? They don't just wake up one morning and be like, it'd be great because I'm going to annoy this guy by irritating him today. Now, they're reactive. They're responding to some other dysfunction somewhere in the body, right? So facilitation can certainly do that. A rib biomechanical change or a ring shift or something like that, that's going to alter the length tension relationships. That's going to make the muscle not real happy, but it's reacting to those sort of things, right? So it's very easy to kind of look and be like, oh, this muscle is really tight. We need to do some we need to do some release here, we need to do some needling here and these sort of things, but we're not treating the underlying cause with that stuff. And so that we might get some improvements with, you know, deep tissue massage or some sort of pressure release technique or dry needling. But odds are within the next 48 hours, those things are going to come right back if the source of that abnormal tone isn't handled to begin with, right? So we see this sort of stuff a lot, does happen quite a bit. And we'll keep talking about it as we go along. I think this is my last slide. Look at me, I'm almost right on time. So,
Woo.
well, it's not my last slide, but the last anatomy one anyway. So neurological stuff. Oh no, I still have vascular. Damn it. It's close. Neurologically, there's kind of two things that I want people to remember. The thorax is what we call very singularly segmental in its innervation. And so what that means is that it's actually able to radiate pain from a non-neurological structure. Okay, we've talked previously about the idea of radiating pain really being more of a neurological pain, right? But in the thorax, that plays it out a little bit differently because it's very singularly segmental. So if I move my trunk, I can get zing, radiating pain that shoots around my trunk because of something like a costotransverse joint lesion. Okay, so that's something that we have to take into consideration there. And we'll look at this more significantly when we do dural testing for the thorax. Okay, there's a specific way we have to do that. And then the sympathetic system is also very heavily invested in this region, so it's definitely possible to get sympathetic reactions, sweating, cold, clammy hands, all these different things from just having them go through active movements to doing our PIVMs and PAVMs and even doing different treatments in this area, right? So because of where the sympathetic mechanism is, this sympathetic ganglia sits right in front of the head of the rib. So if we're doing something that might move that, and the sympathetic system's already sitting at a very high gain, we can have sympathetic reactions that do occur. And those can be pretty uncomfortable for patients when they happen like that. Okay, let's see if we can get through this one. All right, so this is kind of what I was talking about previously. These radicular arteries, right? So anterior and posterior kind of comes off of these intercostal arteries, and they come in and they kind of come together here in order to fill these anterior spinal and posterior spinal arteries, right? But in a lot of cases, like I was saying, not everybody is going to have one of these at every single level of the thorax. In fact, most people don't. So there's a high percentage of people that have what they call this artery of Adamkiewicz, where it's one really pretty big radicular artery helping to fill in a lot of this vascularity, right? And so that creates this watershed mechanism where if we have a impairment of the blood flow into any of this area, it's where does this blood flow, how do we compensate for that? And the answer is if they don't have a lot of additional methods to get blood flow into this area, they don't compensate for that. And all of a sudden, now we're getting neurological symptoms as a result of decreased vascularization. Okay, so that's also something that we have to take into consideration when we start to find this stuff. But if we have this, from our perspective clinically, what are we going to have? What's the sign that's going to show up that's going to give us a clue that this is going on? Well, if it's affecting the cord, we're going to have upper motor neuron signs. So that's going to give us an idea. We're not supposed to be treating this person anyway. They need more medical examination, and we can certainly mention maybe it's a vascular issue, but it's not really up to us to find this. It's just a matter of the idea that, hey, we need to know that upper motor neuron symptoms don't always necessarily come from compression of the cord. It can come from lack of vascularization to the cord as well. Okay. Yep, got all that. Yep, and again, bleeding, we talked about this a little bit previously, but the idea that anything that's going to take up space, so blood in the canal is going to take up a lot of space, and since there's less space within the canal here in this body region, it's going to potentially cause more issues. All right. We did it. We got through everything, just a couple minutes over. So, any burning questions on any of that? Like I said, I tend to go way more in depth than we need to be, but it's good to, I think, to have some of these thought processes as we go through this stuff, because I think the more you know about the anatomy, the more you know about the biomechanics, the more you can pick apart some of the unusual presentations that might pop up when a patient comes into the clinic. So again, more than you probably need to know on a daily basis in the clinic. But it is important to understand these things, the different orientations we talked about with the different costal facets and the facet joints themselves and all that sort of stuff. So again, we'll go more into that as we get into the biomechanics over the next couple of sessions. Anything else you want to add there, Dave?
No, that's pretty solid. I think that's a full session right there. Again, I will work to get this recording up, hopefully by today or tomorrow. I've had some computer issues, but I should be having it sorted today. So maybe it'll be easier for me to get this up. I know there's a lot of detail, but there's a lot of good information here. It's worth going over. What are we doing next week, Eric?
Next week, biomechanics would come up next.
Okay.
So again, it may spill over into a couple of sessions,
Yeah.
depending on how we want to go into those. The hard one is always going to be as we get to combined motions, and how much of that do we really want to get into on a Zoom call versus doing it
Yeah.
in the lab. I think it's good to have an idea of what's going on, but we can kind of talk about that as we go
Yep.
through. And next week's going to be a tough one. I'm actually leaving town. My son's got a tournament out of town, so
Let me know what you want, Eric.
What's that?
I can cover a topic too. So if you're traveling,
yeah, so that might be a situation where I might have to do that. I'm not sure what time I'd have to. I might be able to get around for the first half of it, but depends on our flight time and things. So, but we can. No problem. I'll text you later this week or early next week and let you know what my situation is.
Yeah, sounds good. Cool. All right, man. Take care.
All right, see ya.